Hello, students. This is chapter 11 on antiviral drugs. We're going to dig into this content and hopefully learn more about how drugs work to stop viruses from reproducing, but we can't really treat viruses the way that we can treat bacteria. So antibiotics only good for bacteria, right? They only kill or stop bacteria. Antivirals help to combat our viral infections. So let's dig in. How so? Will they interfere with a virus's ability to make more virus, right? They can be toxic to our human cells, so we want to be careful. And they're very difficult to develop. We found that with the COVID-19 antiviral medications. Although we do have some that will be hitting the market soon, we do not. We were not able to produce those as quickly as we wanted to, as far as the medication to treat or help combat that virus. Okay, uses for antivirals. We currently have antivirals for cytomegalovirus in patients that have received a transplant. We have antivirals for herpes simplex virus 1 and 2. So, our genital herpes, and also herpes zoster, which is going to be like our shingles. And then HIV, we have antivirals that we can use for that to help to keep the counts above that level that would make them progress to AIDS. And we have antivirals for influenza A and for influenza B, RSV, our respiratory syncytial virus, and hepatitis B and C. Okay. So keep in mind, just like, you see hepatitis C there, you see HIV there. These are not necessarily, and you see genital herpes there. These are not necessarily going to get rid of the virus, right? They're just going to slow it so it can't reproduce. So this really helps with the symptoms. Unlabeled uses, sometimes we see cytomegalovirus, antivirals, and antivirals given for cytomegalovirus and herpes simplex virus infections after a transplant. And also sometimes we give antivirals for varicella pneumonia. Okay, adverse reactions, especially if they're liquid. So we see liquid antiviral suspensions like Tamiflu given for the flu, right? So regular old flu A and B that we get every year. Tamiflu can help with the symptoms of that. So it has GI reactions, right? Side effects, especially if it's an oral suspension, nausea, vomiting, diarrhea. Other reactions to antivirals include headache, rash, fever, and insomnia, which is the inability to go to sleep or stay asleep. Contraindications for antivirals. Obviously, if you're allergic to the medication, we probably don't want them on it. And then some examples of antivirals. So one of them is Cidovir. I'm trying again, guys. Cidofovir. There we go. Cidofovir, ribavirin. And then as we move through, we're going to see some more. Antivirals that we use. Tamiflu is one of them we're going to learn about. And then we'll talk about antiretrovirals. So if I can get this out of my mouth, we'll see. Cidofovir or Vistide is contraindicated for patients that have renal issues and for medication, and to be given with medications that are nephrotoxic, like those aminoglycosides that are hard on our kidneys and our ears, right? And then ribavirin is contraindicated for patients that have unstable cardiac disease. So we don't want to give this to a patient that maybe has unstable angina, or they have a percentage of a blockage or anything like that. We do know that in rare cases, ribavirin can cause fatal heart problems. So we really don't want them to take it. It's also not approved for anyone under the age of 3. So there is that as well. And then we have, I told you about the Tamiflu. This is oseltamivir. And I can't pronounce these. You guys are just going to have to bear with me. I come from a Southern family, and these words just don't come out of my mouth correctly. So the name brand of Tamiflu is a lot easier for me. Side effects with that, we talked about GI symptoms, but also sometimes these patients end up with nosebleeds. So that is a pretty common adverse effect to Tamiflu. So be on the lookout for that one. They are really careful. So precaution for Tamiflu with patients that are pregnant. Although they can take it, they prefer not to have them take it. And then anybody that has like a neurologic problem, May not want to take Tamiflu. We know that there can be some sudden changes in mood or behavior, especially in children. We've heard some crazy like psychosis stories of patients taking Tamiflu. Okay. Oh, there you go. Used during pregnancy and lactation only when the doctor has determined that the risk is less than the benefit, that we're going to get more benefit than risk for our fetus. And then use cautiously in patients that have issues with their kidneys. They already have low blood cell counts. They have a history of epilepsy or a history of respiratory disease. Okay, interactions for antivirals. And there are a lot of them. We don't want to give antivirals with probenecid because it can increase how much antiviral is circulating in our system. The same thing with your cimetidine, especially with valciclovir, which is our Valtrex, right? We don't want to give valacyclovir with cimetidine because it increases how much antiviral is in our blood. Ibuprofen actually interacts with the antiviral Devoir. It increases the amount of that antiviral in our drug. Imipenem celastatin, which is it is an antibiotic. It's one of those carbapenem antibiotics. We don't want to give that one with ganciclovir because there's an increased risk of seizures. And then anticholinergic agents, so things that help to dry us up. We don't want to give with amantadine because it increases the adverse reactions to your anticholinergic, things like dry mouth and constipation and things like that. And then theophylline, we don't want to mix with acyclovir because we end up with increased serum levels of the theophylline itself. So let's stay away from that one. I know there are a lot of antivirals here, and if I'm being 100% honest with you guys, we do not give these as often as you would think. These are really specific to viruses. Most viruses we allow to run their course. These are going to be your really sick patients that are going to get an antiviral medication. Because of that, at the LPN level, it's nice to know that most of these end in the word or in the letters VIR or CLVOVIR, so that you know that they're an antiviral. I would encourage you guys to learn this category as a class versus focusing on those individual drugs. I feel like it's going to get very confusing. It'll be hard to differentiate them. And there's so many different ones that is a whole lot of studying, not necessarily a priority for this chapter in this unit. Okay, so focus on these as a class. Know that they end in vir or clovir, and that's how you can distinguish them as antivirals. Okay, let's talk about antiretrovirals. So these are another type of medication used for viral infections. Antiretrovirals are more commonly used for HIV and also for herpes, right? So we do see them used in herpes and HIV. Antiretrovirals work a little bit different. They're interrupting the reverse transcriptase process in DNA synthesis and getting those nucleotide analogs or the matching sets, right? So they unzip the DNA of the virus. So we have an approach to this. It's called HAART, highly active antiretroviral therapy. And there are different types of inhibitors that we use within HAART, right? Protease inhibitors inhibit the enzyme protease. Reverse transcriptase inhibitors inhibit the enzyme reverse transcriptase. Kind of see where we're going here? Non-nucleoside reverse transcriptase inhibitors inhibit the enzyme reverse transcriptase, right? But they do it a little bit of a different way. Early inhibitors and integrase inhibitors, you're going to learn more when you do your concept guide. I do have lots of good information on that. So make sure you're meeting up with your SI leader, Destiny McLemore, and going to those SI meetings on Thursday. You do need to know just the basics, just what we talked about. Protease inhibitors inhibit the enzyme protease. Reverse transcriptase inhibit the enzyme reverse transcriptase, because protease and reverse transcriptase are used to make make the viruses, right? To synthesize the DNA. Okay, we use these, like I said, for we can use them for HBV, but also for HIV and AIDS. We also see them with herpes. Adverse reactions include GI reactions, so your nausea, your vomiting, your diarrhea, changes in your taste, but also headache, fever, chills, and rash, and those signs of neurotoxicity. So watch for that circumoral paresthesia or numbness or tingling around the mouth, and then also peripheral paresthesia, which is numbness or tingling in the arms or legs. These are contraindicated in patients that do have a history of allergy to the drug and patients that are lactating, because this is spread through breast milk. Any patient who's taking cisapride, pimazide, triazolam, midazolam, or an ergo derivative should not take these medications due to potential interactions. And they're used cautiously in patients that have diabetes, liver issues, that are pregnant, or have a hemophilic condition, which means that they have a bleeding disorder, right? So we will move on. Antifungals are an interaction with antiretrovirals because they can actually increase the amount of antiretroviral that is in our system. Clarithromycin increases the serum level of both the clarithromycin and the antiretroviral. So this is kind of, if we're thinking back to Unit 1, this is kind of one of those synergistic reactions between the drugs. 1 + 1 = 3. We're getting more of a response of both drugs when we give them together. And then sildenafil, increased adverse reactions to our sildenafil. We don't want to mix antiretrovirals with sildenafil. And this is one we see a lot actually in our patients coming in with these types of adverse reactions. So if you don't know what sildenafil is, it is a Viagra, right? And so patients that are on antiretrovirals, maybe for herpes or for HIV, that they combine that medication with Viagra, they can have some pretty serious side effects of the antiretroviral and also the Viagra. They're kind of also a synergistic reaction, as well as the clarithromycin and the antiretroviral. Now, some of them you're okay to take Viagra with. You just need to talk to your doctor. It does change the way that your body absorbs the concentration. So you might see some of them be prescribed because they're more compatible if your relationship requires that sildenafil prescription as well. And we know that HIV can actually sometimes cause erectile dysfunction, so our males are more likely to be taking the sildenafil. Okay. Opioid analgesics, there's a risk of toxicity when we take them with the antiretroviral ritonavir. Okay, anticoagulants, anticonvulsants, antiparasitics. We don't want to give them with that because it decreases the effectiveness of ritonavir. So ritonavir, if that's the antiretroviral you're prescribed, let's make sure you're not on a blood thinner, a seizure medication, or an antiparasitic. Interleukins can cause potential antiretroviral toxicity. Fentanyl and antiretrovirals mixed together increases the level of fentanyl in your blood. We can think about all the reasons why that might not be a good thing as far as neurodepression, respiratory depression, etc. And then oral contraceptives and antiretrovirals interact to cause decreased effectiveness of birth control. So use an alternative form of birth control. Rifampin, that's our TB med, right? Mixed with efavirenz or nevirapine can cause decreased serum levels of those two antivirals. Okay, let's move into this nursing process. And then we'll do just a quick review of what's most important to know about antivirals and antiretrovirals. So determine the patient's general state of health and resistance to infection, get their vital signs, write down their symptoms, their complaints, and then do a really good head to toe with focused assessments in areas depending on if they have or what viral infection they do have. And that's before you give the med. On an ongoing basis, we're going to be monitoring for and reporting any adverse reactions and looking at an IV site over and over again to make sure we don't have signs of phlebitis like redness, inflammation, swelling, or pain, and that we're reporting those to the doctor. Okay, risk for imbalanced nutrition, less than body requirements. We might see decreased intake. We're going to talk about that in a second. Risk for impaired skin integrity, risk for injury, body image disturbance, and acute pain. And as we move through this to the intervention, we're going to talk about why and what we can do to counteract this nursing diagnosis. Planning, our goals are pretty much the same. Optimal response to therapy with a management of our reactions, and our patient understands and complies with the drugs. Implementation. So promoting that optimal response to therapy. What can we do? Allow the patient and family members to ask all the questions that they need to ask and talk to us about how they're feeling. When we're going to give amantadine, we need to observe the patient for adverse effects because we have some of those more serious ones with the amantadine. With ribavirin, we want to discard and replace the solution in the generator every 24 hours. And we also want to be looking at their respiratory function, making sure that there isn't any kind of compromise. This is also an extremely dangerous drug for pregnancy. It's a pregnancy category X drug, so no pregnant people on ribavirin. For nutritional imbalance, we want to help them with that nausea that they experience when they're taking the antiviral and antiretroviral. We want to keep the atmosphere clean, free from odors, so they want to eat. We want to give them good oral care, which stimulates their appetite before meals. And if their nausea is really severe, we want to tell the doctor so we can get something on board for them. Impaired skin integrity, if they already have skin lesions from their disease process or their viral process, we want to look at them and watch them for worsening or lack of improvement. And if we're giving medication, so an antiviral, antiretroviral by IV, we want to be closely observing that injection site for signs of phlebitis, so redness, swelling, irritation, and monitoring their vital signs. Risk for injury. We need to monitor all of our acutely ill patients very carefully, making sure that they have call lights, maybe making sure that they have planned activities, they've got nice rest periods worked into their daily schedule. And we're looking for those signs of developing neurotoxicity like peripheral neuropathy and circumoral neuropathy, or circumoral paresthesia. Okay. Body image disturbance. So if your patient has a change in appearance due to their medication or the disease process, maybe they're losing weight, maybe they are just looking more ill, we need to spend time with those patients and have them talk to us and really be a non-judgmental, open, trusting environment for them and allow them to share how they're feeling. Acute pain, we want to assess our patients for pain whenever we do our vital signs. Also, we want to, get a really thorough pain assessment using our acronym OPQRST: onset, palliative provoking factors, quality of the pain, right? The region, or if it's radiating, the severity or intensity of the pain, and then how long that they've been in pain, right? Explain the dosage regimen to the patient when we're educating them and advise them to take it only as prescribed. Make sure that they know what those adverse reactions to look out for are and which ones they need to call the doctor about, and develop an appropriate teaching plan to help support their compliance. An evaluation, if we've achieved our therapeutic effect, hopefully our symptoms of our disease process are a little bit less intense, and we identified, reported, and managed any adverse reactions. The patient and family were able to demonstrate understanding of the drug regimen, and the patient verbalized the importance of compliance. Okay, so before we move into these questions, I want to just reinforce a little bit of information. So we talked about antivirals, right? We talked about how antiviral medications help to stop or slow the reproduction of virus so that we have more virus so we decrease the amount of virus that's invading our cells and causing an issue, okay? Some antiviral medications are topical. Think herpes, right? Some of them are creams or ointments that we're placing on the patient, or that the patient is placing on themselves. So when we have a medication like that, a topical antiviral, we really want our patient to know that taking it isn't going to treat it as far as get rid of it, right? So they're still contagious. They still need to avoid having intercourse, even if they're using a barrier method like a condom. We really don't want them to have sexual contact whatsoever. We really want these patients to put on gloves or a finger cot when they're putting this medicine on. That way they don't get it on their hands, right? And it's not absorbed through the skin in other places that are not the lesions. And then we want them to cover all of those lesions and keep them nice and dry. Okay. So I know that was verbal. If you need to pause the video and go back and re-listen to that, that's really going to be important about topical antiviral medications. And then I want to talk to you briefly about antiretrovirals. So with antiretroviral medications, we use them for herpes, we use them for HIV. Just know, like we talked about in the video, that protease inhibitors block protease enzyme, and that helps, those new viral particles not to be able to like mature and then move into the cells. And reverse transcriptase inhibitors block reverse transcriptase enzyme, right? So, and that's so that the HIV material can't change into DNA inside the new cell, so we can't copy it, right? Non-nucleoside reverse transcriptase inhibitors really latch on to that reverse transcriptase molecule, so it can't make new DNA. Integrase inhibitors prevent enzymes from inserting their material, right? So if it's in the name, like protease inhibitors, reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, know that it's working on that enzyme to block it, right? The word inhibitor means blocked. Okay. I feel pretty good about that. That's really all I want you guys to stress out about here. This is a really in-depth topic, very high-level nursing. Let's test the knowledge that we have. Is the following statement true or false? A virus is larger than a bacterium. That is false. Viruses are smaller than bacteria, and to reproduce, they can't do it on their own. Viruses are stuck. They need to borrow a cell from the body. So they actually invade our existing cells to reproduce. Things such as the common cold is a viral infection, and then we can go all the way up to like HIV, right? So viral infections, there's many different types of them, many different severities. Is the following statement true or false? In most situations, antivirals have major adverse reactions. This is actually going to be false. Most of the time, it's just those GI issues and flu symptoms. Okay. Is the following statement true or false? Antiretroviral drugs are used primarily to reduce viral load in patients that have HIV. They reduce the viral load in patients with HIV. Yeah, so this is primarily how we use antiretroviral drugs, although we talked about using them in other patients as well. Multiple drugs, that heart therapy, right? Highly active antiretroviral therapy is used to help attack the virus so that it can't reproduce. But we're trying to reduce the viral load so we can increase healthy CD4 cell counts. Otherwise, they're going to progress into AIDS. Okay, so that is it for antivirals, antiretrovirals. Now that's some pretty dense content, and obviously my inability to pronounce some of those drug names may have been a little bit distracting or confusing. If you have questions, don't hesitate to reach out and I'll be happy to help you get there. I will see you in chapter 12.